Good afternoon, everybody. Now that we're already past the top of the hour, just a couple minutes. My name is Alex Valencourt. I am the president of CSOHIMSS, and I get the privilege of introducing our CIO panel, who is going to help us over the next hour and talk about their experiences. Before I do, want to make sure everybody's had a chance to rejoin from our breakout sessions. And this will be our final component to our session from last week and this week. So I will start off with some introductions and then we'll get into a couple other topics here. I'm going to do this in alphabetical order. So Gary, I think you're up first. Mr. Gary Ginter is the CIO and Senior Vice President of Premier Health, a healthcare organization in Dayton, Ohio. Mr. Ginter has over 30 years of IT or IS experience and has been in the role of CIO at Premier for the last 7 years. So Gary, welcome. Thank you for joining us today. Andy, you're up next. Mr. Andy Lehmann is the CIO and Senior Vice President at Kettering Health Network, also in Dayton, Ohio. Kettering is a non-for-profit network of 9 hospitals, the Kettering College, and over 120 outpatient facilities. Kettering is committed to transforming healthcare experience with world-class health services for every stage of life. Kettering is an IBM Watson Top 15 network and a Fortune 100 Great Places to Work recipient. In his role, Mr. Lehmann oversees the development of the overall strategic plan and financial goals of IS, as well as the daily operations. He has a Bachelor of Science in Chemistry from University of Richmond in Virginia and an MBA from Indiana Wesleyan University. So welcome, Andy.
Thanks.
And then also with us today is Craig Richardville. Craig is the CIO and Senior Vice President from SCL Health, joining us all the way from Denver, Colorado, an organization that operates 8 care sites and more than 100 physician clinics, including in addition to home health care, hospice, and other facilities. In his responsibilities, he leads all aspects of the health system's IT strategy and operations, including enterprise systems and applications, information security, core infrastructure, and leading the system's digital transformation and information automation. So welcome, Craig. Thank you very much for joining us.
Thank you.
All right. So before we start into, I'm trying to switch notes real fast. So before we do that, what I'd like to try to switch to briefly is every year, CSOHIMSS has the honor of awarding scholarships to students who have gone through kind of a rigorous application process. We talked about it a little bit this morning. And those scholarship winners we get to announce here. So I'm going to ask Gary, if you wouldn't mind helping us introduce our first scholarship winner.
Okay, sure. So I'm announcing the CSOHIMSS Student Scholarship. It is awarded to a student who demonstrates academic excellence and the potential for future leadership in the healthcare information and management system. The winner this year is Mami Sek. Mami is a senior at Miami University Health Information Technology Bachelor Degree Program. The scholarship committee notes in particular Ms. Sek academic achievement and perseverance in her studies devoted to improving healthcare. Congratulations.
Great, thank you, Gary. Congratulations. All right, and Andy, do you want to tee up our next scholarship winner?
Sure. So I'm going to announce the winner of the Jane Blank Scholarship. This scholarship is awarded in honor of Jane A. Blank, an early leader in health IT. The scholarship is awarded to a student who demonstrates academic achievement, service activities, technical skills, career goals, and demonstration of leadership potential. Our winner, Roshanak Basti, is a student at University of Cincinnati Master of Health Informatics program. The scholarship committee notes in particular her volunteer work in promoting health IT and her interest in improving healthcare throughout the study of informatics. So congratulations to our winner.
Great, absolutely. And thank you, Gary and Andy, for helping us. So I hope our recipients are still on today. I noticed earlier in a couple of our sessions that they were able to join us. So thank you guys very much. Thank you for the application process. Our scholarship team led by Donna Evans from our Miami University informatics team leads that with a scholarship committee, and so pretty competitive process. And so congratulations to you guys on the award. There is a monetary amount that you guys will be receiving if you haven't already. We'll be sending that out shortly. So thank you again. All right. Back to our CIO panel. And I'm not sure what order we've got. There we go. Look at that. I'm going to take the slide deck down. I think this is a little easier. There we go. So we have a list of a few questions that we want to try to ask our CIO panel today. And what I would ask from our audience is, again, you probably heard this numerous times today, please make this as interactive as you would like. You've got some great leaders here in front of us who can share words of wisdom from their experiences in their own organizations. So there is a Q&A function at the bottom of the screen. Would encourage to try to make this as interactive as possible. So with that, we'll start off with some of our questions that the board came up with, and then hopefully can entertain more questions from our audience as we go. So before we start into the questions, can I ask each of you to tell us a little bit about your organization and how that has evolved in the last several months, the last 8 months as it relates to COVID. So Gary, you want to start us off?
Sure. So Premier Health is a 5-hospital system in Dayton, Ohio. We go probably 30 miles to the south and 30 miles to the north. And we consider like an 8 to 9 county region, part of our region that we support. We have roughly around 1,500 beds, $2 billion revenue each year. We have roughly around 12,000 employees and a large primary and specialty physician network. The last 8 months, I'm not sure, I don't want to really get into your next question, Alex, but how it's changed, it's just interesting as this pandemic started, how we've progressed from where we started and getting ready for the surge, working in the region, and we did not see that surge, but the numbers we're seeing now, I just think back to where we were 6 or 7 months ago, that if we had the numbers we're seeing now, what would have been different 6 to 7 months ago, I guess is what I'm trying to say. Because it's interesting, because now it's just almost like business as usual, but those numbers would have put us into a hysteria mode 6 to 7 months ago. So it's just kind of interesting to see how the organizations, all of our organizations have morphed over that time and how much we've learned in those last 6 to 7 months.
Yep, good. And I think we're all learning from this still. Andy, you want to tell us a little bit about Kettering and similarly?
Yeah, sure. Candidly, in a lot of ways, we're very similar to Premier in terms of size and scope. We have 9 hospitals that in many ways service the same geographic footprint that Premier does. We have a big primary care and specialty employed physician group, which we support. And to get to the question, Alex, about what have we seen really change? I think for all of us in healthcare, we're aware of the pressure being applied by really macro forces to change healthcare with the intent of improving care and lowering costs. I mean, I don't think that's news for anybody. And I think going into the COVID crisis, those forces were at work, and we were all trying to adapt to how do we continue to improve quality outcomes, lower cost, and capture that essence of the move to value, if you will. What COVID did specifically, at least in Gary in my neck of the woods, I'm not sure where, I'll be interested to hear what Craig has to say about it, but at least in Dayton, you know, when the governor shut off elective procedures, the P&L for the hospital systems took a major hit. So suddenly we were faced with this sort of dichotomy of get ready for a big surge of patients, while at the same time coming to grips with a P&L statement, which was basically being, I don't want to say collapsing, but was significantly impacted. And I know at Kettering, when we looked to do things like, you know, we had to, with a huge portion of our P&L being labor costs, you know, we had to look to furlough people, you know, to reduce costs, while at the same time planning for a massive surge of patients. And that's a really strange place to be in a business, I think, as we would all appreciate. And I'm guessing most of the listeners were there as well. So what we've seen since then is some degree of return to normalcy, as Gary indicated. But by the same token, there's still a lot of pressure to right the ship financially. And I think we're all feeling that, Alex. I think there's just a reality there that can't be ignored. I think we're all in this for the right reasons in terms of taking care of patients and trying to figure out how to really deliver high quality patient care. But if the margin isn't there, we struggle. And I think all of us have taken a pretty big hit, and we're still fighting through that. That I think has been a big change. So.
Yeah, thank you. And we may come back to that topic a little bit on some of the financials and see what we're doing going forward. So thank you again. Craig?
Yeah, thank you.
Background about your organization, and similarly, what's going on in COVID world in your space?
Sure. So we're a $3 billion healthcare system headquartered in a town called Broomfield, Colorado. And Broomfield is between Boulder and Denver, about 10 minutes from Boulder and 20 minutes from Denver. We sit on an Oracle campus, actually. So our headquarters is mixed in with 7 buildings that are owned by Oracle, so very high-tech area. We have about 20,000 teammates across our system. We are a faith-based system and Catholic, a little more specific. Our services are the state of Colorado, the state of Montana, and we also have some safety net facilities in Kansas. We are the merger of 2 healthcare systems. One was the Sisters of Charity based out of Leavenworth, Kansas, and another one called Exempla that was based out of Colorado. You know, when you look at some of the changes that we've seen within our communities, probably first and foremost is we live in a very competitive environment. Denver is extremely competitive. A handful of healthcare systems, pretty well equally sized, all competing with each other. But with COVID, you really saw a big collaboration on the administrative side, the executive side, the clinical side, and it really was a very unified healthcare system industry that was looking to try to treat this. We've gone through several different surges, for example, in preparations for, and probably the biggest one at the moment is actually occurring in the state of Montana. And one of our facilities last night, actually the government flew in a DMAT team, which is the disaster medical assistance team. About 30 providers flew in last night, and we got them up and running, and they're providing services to some of our facilities in Montana due to the surge that they're currently receiving. So, you know, it continues to be a very evolving situation, and I think for all of us, I think the fact that we're coming together as an industry to serve our communities and our patients is really stellar and something that we all should be proud of.
Yeah, great. Thank you for that. All right, so a couple questions. You know, we've all heard some of the supply chain issues with PPE. Can we cover a little topic here on what have you seen with other supply chain issues, and specifically what have you done to maybe adjust either during COVID or permanently for any of your supply chain challenges. And so can you talk to the audience a little bit about some of that? This time, why don't we start with Andy?
Sure. Over the years, Kettering Health Network has evolved as all organizations do, but part of our evolution, part of our growth has been through the addition of hospitals. As mentioned, with 9 hospitals geographically dispersed, some of which we acquired over time, some of which we built, but some we acquired. Kettering's ability to truly function as a network is a challenge at times because of that. And when we talk about supply chain and efficiencies in supply chain, I think Kettering continues to evolve how we approach the supply chain as a network versus individual campuses, for example, or individual institutions. So as it relates to PPE, Alex, a good example of it is, when COVID really hit, when the ramp up to COVID really hit in terms of our operational changes in March, we really took the inventory of PPE seriously, like I'm guessing most people would, which started to say things like, well, how much do we have and where is it? Sort of basic fundamental questions about what are the supplies that we have and where are they located and how do we make sure that we can get them to the places where we need them. So from an IT perspective, we immediately put in place analytics and insight into our own inventory of supplies so that we could better deal with the potential surge. And it sounds so simple when I say that, but at the time, to try and understand across, 10 counties, multiple hospitals, physician practices, what we've got and where it is, that was a pretty significant effort. And our analytics team did a great job providing the insights into what was truly going on with some of the PPE that we absolutely needed to have. And then as a result of that allowed the folks who run our supply chain then to better understand, okay, what do we need? How do we work with our vendors to bring in what ultimately we think we're going to require? So just some thoughts on the supply chain. So,
did you see, if I can, did you also see some of that impact within the IT space? For example, we've all heard some stories about getting access to laptops and even servers.
Oh, yeah. Oh, yeah. So, video cameras suddenly were the hot item,
I can imagine. Yep. All right. Thank you, Craig.
Yeah, I would ditto everything Andy said. I think it was important to act as a system to make sure you had accurate inventories. They could do predictive analytics as to when you may be needing additional equipment or other supplies, and be able to move things in between. We're several states and we have states in between some of our assets. So be able to move things around in a very quick manner was very important for us to kind of fine tune that system. I do think also, one of the things, we had several partners come into place, like Hunter Douglas, for example, started making some supplies for us, things of that nature that are headquartered here in our region. And that was really, again, kind of a community effort of not only healthcare, but non-healthcare people coming together to try to increase the supplies that we have. I think also one of the things that I found very good for us is that, having the accuracy and the preciseness of what type of equipment you had and where it was at. So, for example, it was no longer, good just to know where a ventilator was at. You had to know what type of ventilator it was, the model it was. Could you move it to a 2 or a 4-person vent? A lot of different ways to try to increase and improve our capacity as we were kind of working through the supply chain piece of it. And I think back to Gary's point right at the beginning, I think this is part of the things that helped us back in, the March, April timeframe to get ready for, these new surges that are coming upon us. We're much more positioned to be able to handle those appropriately.
Nice. Yeah, very good. Thank you. And Gary?
Yeah, the only thing, I mean, it's all, we're dealing with the same stuff. And, I think from a sourcing standpoint, they went from the trying to do a just-in-time inventory to you can't count on that anymore. Because one, you don't know how the surge is going to be. We went from the tracking, as Andy mentioned, of having a daily tracking of how many days that we were anticipating of having PPE, supplies on hand. But I heard our sourcing VP the other day just saying, okay, now the surge is hitting again. But we're, as you're trying to control expense and look in those financials, we're going to have to purchase, because you can't count on vendors delivering when they say they're going to deliver, because everybody's after the same supplies. And so really you're having to have much more inventory on hand than we would ever have had in the past. And that's just something else we've had to adapt to. And I would say the other thing, as we got into the pandemic early on, is just, to your point about IT equipment, it's down to the basic things about tents. And as we created these drive-through testing sites, as we created these external tents outside the emergency departments, so to handle, there was a lot of sourcing activity to try to iron down all that equipment, all those supplies needed for those different kind of situations that we had never experienced in the past.
Wow. Yeah, I heard a story from one of the supply chain execs that, the minimum order for masks was 2 million. And most organizations can't afford, 2 million at what? Then they would go in from $5, what used to be 80 cents a mask and now $5 a mask. And so, paying $10 million. And I heard stories of organizations that started to try to partner. If each of us wanted, 250,000 of, or 500,000 masks, then we'd go together, pool our resources, and interesting challenges there.
Right.
So good. The other question is around telehealth. And we've heard, between today's presentations and last week's presentations, a lot of conversation, particularly around telehealth and other opportunities, within trying to connect with patients in a more virtual manner. Can you describe a little bit on how your organizations have tried to tackle that and what that's meant to, you guys in the IT space and your teams? So Gary, can I start with you?
Sure. So, we were working on that before pre-COVID, but with limited success, I would say. And with a lot of things, COVID definitely escalated a lot of that capabilities. What happened though was, we started into virtual and we're using a third party to do it. Then we started transitioning to our physicians do it. Then COVID hit. And so we were working with some of our partners to shore up to make sure that was working. But then what did our physicians quickly do? They went to the doxy.me. That was a free solution out there and allowed them to do the video capability, but not totally integrated within the Epic solution. And so we kind of had two different models out there. One of the things that was very interesting to do it, again, as you get into these things, is just the procedures and processes around doing video visits. And we definitely, our physicians adapted to it. And, in April, May timeframe, that's the majority of what they were doing. But it was interesting of how quickly they were transitioning. They were still calling telephone encounters video visits. Because if they couldn't get the video visit to work, because either the patient in, the doctor in, they quickly went to a telephone encounter. They still called that a video visit. And it's really, we still are having these conversations of, the process needs to be, you may need to do a little pre-work with patients to make sure that they have the capability on their end, that you connect the video and so on and so forth. But what we saw was a huge spike in the April-May timeframe. Now that we're 6 months into it, 7 months into it, it has definitely come down as we've opened up some of the offices back, but we're still much higher than we were pre-COVID. So I think it'll continue to transition, and it's not going away. But I also don't think we're ever going to get up, to the level we saw in the April-May timeframe.
No, good perspective. Andy?
So, I think when I think of telehealth, I always have to like immediately compartmentalize what aspect of telehealth we're talking about, right? So there's the direct to patient telehealth, and then there's the provider to provider telehealth, and then you can further break those down into sort of ad hoc telehealth versus scheduled telehealth. And when it's a very similar story to Gary's in the sense that the direct to consumer, direct to guest, direct to patient, however you want to characterize that, telehealth, COVID just absolutely catalyzed it. We saw the growth from 1% maybe up to 40% in April and May in terms of visits with patients and their ambulatory care provider. So it was a huge explosion of telehealth in that sense. And maybe just to speak to some of the other nuances of it, I mean, one thing that became really important in the COVID units in the hospitals was how do we make sure that we're not exposing specialists, for example, to the disease? And a great way to do that is telehealth consults, So it wasn't just in the outpatient environment that we wanted to focus on telehealth, but how do we enable that technology to meet the need in the inpatient world as well? And then I even would include sort of the really sad cases of an individual who was dying of COVID in a COVID unit, who is basically by themselves other than care providers coming in. And how do you make it so that their family can reach out to them and be with them? And how can we put technology in place that really enables that aspect of healthcare, which we can never ignore, which is those extreme examples where care is being provided. So, sort of the telehealth umbrella, Alex, in my mind, is pretty broad. I think what Gary described is spot on. A couple of other nuances to it, just to try and round out the conversation, I guess. So.
Yeah, so it sounds like you guys were doing some of the bedside, video chats for patients to connect with their families and some of those kinds of things.
Sure.
Totally agree.
Yeah.
Thank you. Craig?
Just to kind of expound on some of the great comments. So I think it's nice that the industry actually disrupted itself. We've all had telehealth type services for a decade with very little penetration, depending on how you defined it. So I'm glad Andy kind of put some context around that, but certainly the provider to the patient, telehealth was low. We all spiked up really high. We're running at about a 10% rate right now of all of our clinic visits that are done to be virtually. I think that will start to slowly creep back up as we understand a little bit more about the financing and some of the complexity. But I think we're feeling a little bit of a pinch that there were some digital technology companies doing nothing but virtual services, coming into some of our markets. So we now have that expertise and we're able to deploy it back out. I'm a big fan of just bringing the services to your patient, put it right in their pocket, right, with the smartphone, with mobility. We do it with banking, we do it with retail, we do it with so many other aspects of our life, but we still would almost require it many times to have the patient come to us. So now we're going to the patient. And I think that's a great change in our delivery of the service and to be able to be more kind of consumer focused. Back to the hospital components, the low to no touch environment is a new norm moving forward. It will be that how do we go ahead and provide the level of service and comfort that our patients expect and deserve by having more of the virtual tools in place. So pastoral care, was a big piece. We deployed hundreds and hundreds of iPads out, both for within the patient as well as to our caregivers and the support services around them, able to allow them to speak to their family and visitors, virtually, because our limits to having a physical person come into our facilities was restrictive like it was in many other places. And I think as this starts to become a little bit more of a norm for us, we are actually working with a specific company who created in the state of Colorado. We're the only state to actually have a digital driver's license. So my driver's license is on my phone. I do have a physical one for when I travel in between states or I'm in a different state, but mine's on the phone. And I think as we start to move ourselves into the virtual world, we've got to make sure we understand who's on both ends of that conversation or that event. So we're looking at developing a digital ID for our patients and for our providers so that we can confirm that it is that patient on the other line that is contacting us and that they are contacting us, and maybe not somebody else that's posed acting as somebody else. So I think that whole identification piece is going to be another level of technology and comfort to know that, you know, who's on both ends of that relationship.
Yeah, I would agree with that. That's good. I didn't know you guys were doing virtual driver's licenses. You know, the other thing we heard from one of our presenters last week, and just to finish this thread out around telehealth, and not necessarily telehealth, but using technology to connect with patients. There was one of our presenters talking a bit about waiting rooms, and the waiting room of the future has changed drastically because we're all now used to waiting in our cars for someone to either call or get a text message that says, you can come in now. Right. And so, you know, another use of technology and trying to figure out. And so, you know, makes you wonder if that's going to become more of the norm with surgical waiting rooms and some of that, right? Radiology appointments, et cetera, if that'll all go electronic and stay that way. So I don't know if anybody wants to comment on that, but interesting from one of our presenters last week.
Yeah, I think that actually is really neat. You know, we've all questioned for years why our waiting rooms are so big, but we shouldn't invest so much capital in the size of these waiting rooms. And I relate it back to kind of like the retail and the financial services of how we are doing things online so much more in our pocket versus going to stores or going to banks. And it's the same thing we do, you know, when we look at restaurants. You know, for years, none of us have kind of like waited in the lobby of a restaurant. We strolled around and walked around. We, you know, did, put on a waiting list, got contacted via our phone. And now, you know, that's coming to our industry as well. And I think it's an expectation for many consumers.
Yeah. I mean, how many of us still have gone into physician offices where you got to fill out paperwork every year? And hopefully that's now a thing of the past. I mean, it was always online anyway, but, you know, you still to get these physician offices out of their existing practices. So, yeah, I think the waiting rooms are a thing of the past.
Yep. I've even seen some of the restaurants now. We got a chance to go to one just about a week or two ago before this new surge. And they didn't pass out menus. And I even asked the waitress, you know, do we get a menu? And she said, oh, no, there's the QR code. You got to scan that and, you know, your menu's on your phone for contactless, you know, type of work. So, so I want to switch and pivot just a little bit around what often we're starting to hear now is COVID fatigue. And so those of us, you know, back in March when this first started and there was this threat of a big giant surge, you know, many people thought that this would be over and, you know, probably around, you know, July-ish. And here we are, you know, it's November and I'm hearing predictions that, you know, this really won't start to fade and subside until 2022 at this point. So what are you guys doing? How do you deal with COVID fatigue in your organization? And do you see a big difference between, you know, frontline staff like the nurses and some of the IT staff, you know, and is there a dichotomy there? Is there kind of a shared interest or a, you know, what does that look like in your organizations? And are you using any technology to help combat some of that? Andy, you want to start us off?
Yeah, sure. So where my head goes initially, Alex, with that question is it's really a cultural question. And that is not to discount what individuals are going through. So I don't mean to ignore that aspect of the question. But when I hear your question, where my mind goes is the importance of the mission of what we do. And the importance of the meaning of the work that we do. And, you know, Kettering's culture is faith-based, and we have been very intentional within our culture about creating the kind of culture that we feel supports our beliefs. And when we talk about the meaning of the work that we do, specifically out of the Christian heritage, it stems from Jesus's healing ministry. And as a result of that, there's a palpable aspect to Kettering's culture, which is there's real meaning in the work that we do, and it ties back to that Christian heritage. And I think that one thing that COVID has done is it's really tested organizational cultures, because we sent people home like a lot of people did. You know, if you weren't at the front line in a hospital, we basically said you can go home and do your work if we can figure out how to make it happen. You know, and anytime you have those kinds of disruptions, I think it really impacts or could impact culture. But I think one of the great things within Kettering is the strength of our culture has continued. And although we have to be intentional about continuing to fill up the cultural bucket, if you will, I think that aspect of Kettering has allowed us to navigate the waters, you know, pretty successfully in spite of everything. And that's not to say that people don't get tired. Once again, I want to go back to sort of the heart of your question in terms of fatigue. But I think when you really feel like there's meaning and purpose behind what you're doing, you can deal with the changes and the hurdles and the obstacles that much more with that much more energy. Let me put it that way. And you know, for my IT organization, we're very clear about why we exist. And the answer to that question in my organization is that we serve those who serve. And we talk about that as a way to permeate the meaning behind our work. We may not be at the bedside, you know, we may not be delivering care within IT, but we are doing everything we can to enable that. And we're making sure that the frontline staff can be as effective as they can be. And that ties us back to our mission. And I think that's just a huge component of COVID fatigue as it relates to what's going on inside Kettering. So
that's a great way to look at it. I appreciate that.
Mm-hmm.
Craig or Gary, do you want to?
Yeah, that was very eloquent, Andy. Thanks for saying that. I think for us and for many others, you know, we always put the patient first. And in order to put the patient first, you have to put your people first. And so how we are taking care of our staff, working through them in terms of trying to provide more services via mobility, some additional monitoring components for them, a digital workforce using chatbots and other types of technology to help relieve some of the human interventions that occur. As we mentioned earlier, you know, we moved people in between states where there was a capacity need or a surge that was occurring. Travelers, they're not around, you know, they're all being taken up by many others and or at rates that are just maybe not feasible. We are starting to look and learn in terms of some of the internal administrative resources that have a clinical degree or a background that maybe have moved out of clinical practice, but still have their licensing and are able to produce, how to get them potentially infiltrated back into some of the workforce. We are looking to see those that have retired or that are retired in our communities to see if they would like to step back out and come into the workforce. As I mentioned earlier, you know, some of the government resources like DMAT, you know, bringing them in to help with some of the capacity challenges or surges that are occurring in different parts of our communities that we serve. So I think it's, you know, it's all hands on deck. It's everybody coming in. I mean, you know, I'll be a runner if that's what they need. You know, the things that I can contribute, you know, on the floors or in the clinics, happy to do anything and everything that's being asked. And I think the core mission of many organizations is certainly, you love it. It's in your blood for a faith-based organization, is that we're all in here, you know, together to make that happen and to help our neighbors if they need that as well.
Yeah, very nice.
And I don't know, I mean, I concur. I mean, I think anybody that gets into the clinical space by nature, you get into it to treat patients, families, community, whatever it is. And yes, to Andy's point, you individually may get fatigued, but in times of crisis, the clinical environments, I mean, even competing organizations get together and treat people. I mean, that's what we do. Now, to your point of the IT staff, you know, I think my staff, you know, we're always dealing with changing priorities, but it's changing a priority like on a Friday as a surge happens and all the redistricting that has to happen. Well, that invariably happens at Friday at 4 o'clock that one of the hospitals says we're going to take a unit, and, you know, well, guess what? You got to get on that right away. So, but we all do that. That's why we all work for healthcare systems. That's what we do.
That's
Yeah, one other comment I'll add is kind of triggered with one of Gary's comments is when you look at many of our administrative workforces, you know, that we did have come on site to be at our headquarters or other administrative areas that are now all remote, you know, certainly 90% in some cases remote. I think we have a luxury now that they're still geographically close and we can call them in from home to help out maybe at a care site. But 5 years from now, you know, as our recruitment and retention and, you know, people are going to be able to, you know, kind of work anywhere across the country without any geographic move. I think it'll be a different look of a workforce. I mean, we all have people in many states, but I think it'll be even spread out more. So if I needed somebody to be physically here, I think over time, that's going to be a little bit more of a challenge that we just got to probably be prepared for how we would bring people in on site if needed, if they're living across the country, and a larger part of our workforce might be doing that, you know, in the system services type areas for sure.
Craig, I appreciate you saying that. You know, it makes you wonder if at some point you start to balance your staff, you know, from East Coast even to West Coast or beyond, right? Because then, you know, your 24/7 mission that you try to support your organization, then you've got some, you know, opportunity there to, you know, kind of staff that way and make sure that there's coverage. All right, so I want to make sure we don't run out of time here. So like many of us, your IT strategic plan and your corporate strategic plan, you know, may have already been set, right? It was, you know, if you've got a 3-year strategic plan and then you've got an IT strategic plan that supports that. With COVID and this whole pandemic, has some of that just been kind of thrown out and say, right now we're just in crisis mode and just put a big giant pause on strategic plans? Or is your organization still trying to, you know, kind of limp along a little bit or put a lot of effort in that? And how do you continue to foster that strategic plan and keep moving forward? Gary, you want to start off on that one?
Sure. So, you know, I would say, again, when the pandemic started, you know, everything pretty much took a pause, I would say April and May. So, you know, just like Andy, we furloughed, you know, especially in IT, we furloughed 40% of my staff. So it was just lights on. No project, all project work stopped, keep lights on. As an organization, pretty much the same thing. I would say as we started opening things back up and opening the access points, you know, and we've had this discussion at the leadership level, you still got to continue on. We're in the 3rd year of our 3-year plan, and we were, you know, at the beginning of doing our 2021 and through, you know, our next 3 years. All that work has to continue, unfortunately. And so, no, nothing, you know, except for those 2-month window there, everything else is still going because it still has to be business as usual. And you still have to figure out how you're going to recover from those 2 months where you pretty much closed the doors and we never saw the COVID patients either. So, you know, it's not only how do you move forward and progress, but how do you recover those financial hits that you took? So no, nothing slows down, unfortunately.
Do more with less.
Yes, that's pretty much the story.
Craig or Andy, how about you guys?
Go ahead, Craig.
Yeah, thanks, Andy. Yeah, for us, We were very fortunate. I did not have to furlough any of our staff. We had to repurpose some people to do some other work, but it was important for us to keep people engaged as we started to figure out what this was looking like. We did go through an evaluation of every single project. And I think to Gary's point, pretty much everything was continuing. We did pause more from a financial perspective just to make sure cash flow and expectations were established with a couple of our projects. But we had several of them that were accelerated too. When you look at some of the digital aspects of what we were doing with chatbots and robotic process automation and things that were going to provide some additional relief, we kind of pulled those in a little bit tighter and started to accelerate some of that work. And we were fortunate. So if you looked at September, for example, Becker's Health, we were one of 8 healthcare systems that they highlighted as having strong finances. Our CEO was our CFO for several years until she became CEO, and so we're very financially strong and prepared for these kinds of instances that occur. But we also went back and looked to see probably what I think is one of a defining moment. Went to all of our partners, everybody that we had a contract with, both in the supply chain side, and I did it personally on the IT side, went through every single one of them and asked for relief. And we got millions of dollars back. And that really highlighted to me of who was a partner, who was going to take some kind of a short-term step back and provide assistance to us. And we didn't know what the future was going to look like. And then who are vendors? Who are those that still want the same thing every month, regardless of the situation that was happening across the country or to your company? So that was really, really nice for us. And so as we start to refocus and redo our work, I've got a list of the people who really were partners. And part of my goal is continue to migrate and move work over to them if I can displace them from somebody who kind of acted as a vendor and really didn't understand what was happening, to our country and to the communities that we serve. So that was a nice piece for me to filter through and figure that out as well. And I will say I was surprised by a couple. Most of them, would probably guess pretty accurately who they are. But a few of them went on one side or the other that I was a little bit surprised on. In some cases, very positively surprised that they would have that kind of a commitment to us.
Yeah, very nice. Andy, anything to add to that?
Yeah, maybe just, I mentioned sort of the macro forces in the industry, that we're all dealing with. So you look at, taking on risk, you look at the legislation that's been passed over the years that we all have to deal with, whether it's, for example, the 21st Century Cures Act, things like that. Things may have been delayed or slowed a little bit, but there's no stopping it. One of the really great things that has occurred, at least in our region, is with the 21st Century Cures Act, where we have to release patient data, notes, and results. Gary and my organization, came together and said, let's figure out how to do this together. And that's a pretty big statement in terms of two competitors coming together and saying what's best for the region, and trying to work together to do that. But it's driven by these larger forces in healthcare that we're all responding to. So, COVID showed up and it hammered all of us in one way, or another. But no one in our government said we're going to get rid of the move to value, right? There is still risk-based contracts that we're expected to operate within, which says lower your costs and improve the quality of care. And I think we all continue to have strategies to go deal with that. It's just over the month of certainly March, April, May of this year, those thoughts were on the back burner as opposed to the front burner. So.
Yeah, and the one thing I'd add to Andy's comment, working together, the pandemic has definitely helped.
Oh, yeah.
Not just with an IT perspective, but things we did in the region, to make sure we had the same visitor policy across the facility. Yeah. Just the collaboration was very exciting to see, because it's just too easy to get in that competitive mode. And, you know, Andy and I have worked together now for years and talked for years. It doesn't always get to the other layers within the organization to say it.
That's well said, Gary.
So Gary, do you think some of that, the camaraderie and the collaboration that we've seen under COVID is going to continue? Or do you think there's going to be just a natural, like, okay, we all came together for a higher cause and a purpose. And then do you think some of that's going to, revert back a bit?
I think in some areas it may stick. I think, again, we're going to be in this for a while anyway. So I guess, time will tell on that. I would hope so. Yeah. But just like everything, if things go back to some form of normalcy, that may change, I guess. But, it just shows when a crisis happens, though, you can come together.
Yeah, agreed. All right, we are almost to the top of the hour here. I do want to allow for any Q&A from our audience. But I have one final question before we do go to other Q&A. So as we've gone through, the theme of our conference has been really around, memoirs of this pandemic and what would we hope that we set up the future of healthcare and IT to look like, 5 and 10 years from now and beyond. And so what would you want to tell or share with the audience that we've learned or you've learned through this whole pandemic? Do you say, be prepared for X, or, in hindsight, think about this kind of stuff? What would you share with future healthcare workers and those in our audience that might be interested? So again, 5 years from now, they think, wow, here's what we brought together. Here's what we were able to accomplish. Don't know who wants to start on that one.
Let Craig go. I don't think he started on
Craig
it yet.
Yeah.
All right, Craig.
Oh, thanks for counting. I appreciate that. I think one thing that's interesting for many of us, I think, been in it for 30 years, is healthcare was in some cases looked by other industries as maybe not being as advanced. And I would always educate other industry leaders that, no, actually, you have no idea how advanced we are. And you look at the data that we have and you look at the clinical equipment and services that we provide, it actually is quite complex and quite very deep and a lot of interrelationships. And so I actually think, as we start to come out of some of these crisis situations that are getting a lot of the attention, that we may be very attractive to some people who may not have thought of healthcare as being a path for them in the technology world to come into us, because I do think we're very well advanced, if not the most advanced industry out there when you look at the things we're doing on the data side now, on the digital side. And the reality is we're not that old. We're only 15 years into being very automated. So that what we've been able to progress in a matter of a decade and a half, other people have taken many decades to get to a certain point. So I think that will be one nice thing of it, to show our advancement, our innovation, our ability to transform. I do think the digital aspects of what we do in our engagements will continue to flourish and allow us to become more part of some of our consumers or patients' lives, and maybe be able to help prevent and be connected a lot more than maybe what has happened in the past due to privacy and other types of concerns, that we may be able to remedy some of that. So some of the contact type software and things of that nature, to be able to stay on top of and be engaged in a positive way with people while still protecting their privacy. And I think really kind of coming really back to just the beginning of one of the conversations was just our mission, that we're here. We're here to save lives, to improve lives. We serve all God's children, regardless of income, race, etc. That I think for many people, that the future healthcare worker will believe into what we're doing and how we're doing it, trying to solve some of the social determinants and inequities that we do have within our industry. And I think it'll be attractive to a lot of very bright people coming into us.
Yeah, definitely a lot of challenges to help bring people to help solve, right? All right, Gary or Andy?
Go ahead, Gary.
I think it was well said. I just think the one thing this has taught us don't be set in your ways. And, you know, I look at this and I just think back, if this pandemic had hit 2-3 years ago, you know, how would we have collaborated across being in a virtual world? Because, you know, we had rolled out Teams last, you know, before the pandemic, but had not seen the usage of it because everybody was in their old habits. You had to meet in a room, you had to travel to a site, you had to do this. And, you know, 2 to 3 years ago, we didn't have Teams or we didn't have a collaboration tool. So what would we have done? But now we're into this virtual world that's not going to go away. We're into these team meetings that happen all the time that I don't think is going to go away. There's just so many of these different things. We've talked about waiting rooms. We've talked about things that historically have just been the way healthcare has always done it. And yes, we've done a lot of digitization in healthcare, but there were still a lot of old processes. And I think, you know, people will be much more open to thinking outside the box now, seeing how quickly we were able to do things during the pandemic.
Yeah, well said. Andy?
So I think if you're a young IT person coming up right now, and the essence of the question is, you know, what would you like to tell people, you know, on a go forward basis? I really think that the importance of leadership only increases as we go forward. And I think the COVID pandemic has proven that. We live at the intersection of two really complicated industries, IT and healthcare. And rarely do I find someone who actually has a crystal ball with any degree of accuracy. And as a result of that, we need leaders who can creatively move through these situations that we have to deal with. And as a result, I think leadership development and the ability for an organization to create that competency is going to be critical on a go forward basis to do what we need to do. I think we can all guess at technologies, and we all, you know, there's a lot there to discuss. But ultimately, we need leaders in place who can advance the purposes that we need to advance and marry the technology into it. So that's kind of where my head goes in that question, Alex.
No, I appreciate that. And good to share that with the audience. So I do not see any questions in our Q&A, and I know we are at the top of the hour, so I want to be very respectful of everybody's time. Truly want to thank Gary, Andy, and Craig for joining us today, this afternoon, and spending your lunch hour with this group here with CSOHIMSS. So thank you guys again for your words of wisdom and sharing that and getting barraged with about a dozen questions. So thank you again.
Thank you.
Thanks, guys. That was fun.
Yep.
Thank you.
Bye.
All right. And then I also, just in closing, since this is the end of our day 2 of our conference, also want to thank all of you, our attendees. And so thank you guys so very much for joining us. I know with, you know, this recent surge now of COVID cases going on, it seems like across the globe, and, you know, healthcare, you know, the CSO team just truly honors the fact that you're spending your time with us over what's potentially 8 hours of, you know, between last Friday and this Friday. Hopefully the content that we were able to bring to this group, as you notice, even with our CIO panel and other speakers, we tried to bring in some regional perspectives as well as those outside of our region, really trying to look, you know, at this pandemic. If we learned nothing, we've learned how to collaborate and bring people together from all over. So want to thank all of our audience and everybody for joining. Would not be remiss without thanking our sponsors again. Thank you so much for all that you guys have done and helping us bring in some fantastic speakers to enable that. So hopefully, again, our content for the sessions, everybody was able to take away something and learn. And hopefully, you know, again, 10 years from now, we're all looking back at 2020 as the year that, you know, healthcare transformation really shaped a new industry and a new norm that we've all learned from very rapidly. So with that, we have not yet set a date for our spring conference, but as soon as we do, which will be in the next couple of weeks, I would encourage everybody to get a chance to attend. We were hoping that spring conference would be physically maybe in Columbus. As we do, we typically go back and forth between the Cincinnati-Dayton and then the Columbus market, but it's not looking like that's going to shape out that way. So probably looking to make that a virtual conference as well, and always open to our members and our presenters on what we could do better to keep enhancing that. With that, we will sign off here. I want to say thank you again, and please be safe and go forth and conquer. We got to get rid of this COVID virus. All right. Thank you again, everybody.
Thanks, Alex.